listening to Everyday Evidence, presented by the American Occupational Therapy Association, helping the occupational therapy practitioner apply evidence to practice. Here's your host, Matt Brandenburg.
All right, today we are joined by Anna Boone and Whitney Henderson. Anna, Whitney, thank you so much for being on the show today to share your knowledge and expertise.
Thank you for having us.
Thanks, Matt. We're happy to be here.
Yes, I'm happy that you're here. I'm excited to learn from you both. You are professors at the University of Missouri, go Tigers, where you research the everyday impact of neurological conditions and cognitive interventions to optimize independence. Today, we're going to specifically be discussing occupational therapy and post-concussion syndrome. So can you introduce us to a little bit of your background? You have done a lot of research and work in neurorehabilitation. What motivated you each to focus a portion of your scholarship on post-concussion syndrome?
Thanks, Matt. So our motivation to study this population really came right alongside the increasing awareness in the public and scientific community on how common mild traumatic brain injuries are, and the general acknowledgement that that impact of a concussion can be longer lasting than we previously thought. With the few million people sustaining a concussion each year in the US, most of those individuals actually aren't getting diagnosed, and the majority of those that are diagnosed don't receive follow-up care or rehab services. The public eye has largely been on chronic traumatic encephalopathy, or CTE, that can occur with repeated concussions over time. But there's also this group of individuals who don't have CTE, but do have persistent symptoms impacting their ability to return to daily life. Because those symptoms would be classified as mild compared to other populations, it's a population that is often overlooked. We basically just saw a gap in care for how best to limit the occupational impact of individuals post-concussion, and saw an opportunity for our work to hopefully make a difference.
Yeah, thank you for painting that picture. It's, concerning to hear that there is a portion of people experiencing chronic traumatic brain injury or a degree of brain injury that is overlooked. And I'm glad you've been able to identify that gap and then begin to research how to provide services for people who need it. Why do you feel overall it's important for occupational therapy professionals to understand and be proficient at providing this type of care?
Yeah, Matt, it's really crucial for occupational therapy practitioners to be both effective and efficient when working with this population, particularly post-concussive symptoms. These individuals often face pretty significant challenges that impact their occupational performance and overall quality of life. Specifically, PCS frequently affects those really high-level instrumental activities of daily living and work, school, and social participation. And these are just areas where we as occupational therapy practitioners are uniquely positioned to evaluate and intervene. Historically, as Anna said, there's been insignificant recognition of the impact of mild cognitive and even emotional regulation difficulties for this population, although that awareness is improving based on some of the things that Anna mentioned. Additionally, our traditional standardized tests often fail to adequately capture some of the subtle cognitive changes experienced by these individuals. And then one more thing to kind of layer on top of the importance is that we do have limitations in insurance coverage. The number of sessions available for intervention is often restricted with this population. And so as a result, it's really essential for us to efficiently identify occupational performance and performance skill challenges so that we can deliver effective treatment really within a limited time frame of work.
Yeah, I really understand the importance of that approach and identifying appropriate standardized measures that can be used in clinical settings. I was able to review some of the research that was published in the American Journal of Occupational Therapy, specifically two publications that you were authors on, one titled Surveying the Landscape of Persistent Concussive Syndrome in Adults Through an Occupational Lens, and the other a feasibility trial examining cognitive strategy training for this population. So I just want to thank you both for identifying a gap in literature and how OT can help fill that gap and provide services to people who need it. And then doing the work to demonstrate and illustrate, hey, like, here's our value, here's our role. And I'd love to ask you some questions about those publications and invite our listeners to check them out. The first being, what really is post-concussive syndrome? How can a clinician begin to differentiate post-concussive syndrome from another condition like CTE?
So that's a great place to start. So it's not unusual for a concussion to result in symptoms for a short period of time of, say, weeks. But post-concussive syndrome comes into play when those symptoms following the concussion are no longer acute, but stick around for weeks to months, and in some cases, even years. And that subset of individuals who have the symptoms for a longer period of time, and it depends on, which report you're looking at, that's anywhere from 15 to 30, 40%. But when you're talking about millions of individuals who have a concussion diagnosis, suddenly that smaller percentage becomes much more clinically relevant for us. And the specific criteria for diagnosis of when you move from, standard general concussive symptoms into that PCS or that post-concussive syndrome phase, the specific criteria do vary depending on what you're looking at. So, for example, it used to be in the DSM, but it has since been removed in the latest edition. So, to my knowledge, the vast majority of PCS diagnoses are coming from physicians who are using clinical reasoning to arrive at that diagnosis. For our work, we chose to include individuals with a concussion diagnosis and symptoms that had lasted at least 4 weeks and rose to the level of actually impacting 4 to 5 at a minimum daily life activities. And the majority of our study sample actually had experienced multiple concussions over time. And on average, they were further out post-concussion than we anticipated. And that was actually at about 2.5 years post-concussion for our sample as a whole.
Wow. So on average, the participants were experiencing symptoms 2.5 years post their initial concussion?
Yes, in our sample.
Wow. What exactly is occupational therapy's role in providing skilled therapy for people, included in this research?
Yeah, so our role as occupational therapy practitioners remains consistent across different populations, right? So it doesn't really matter the population. We strive to take this top-down holistic approach to evaluation and intervention, and that's the same with this population. So we begin by first assessing various areas of occupational performance, and I think it's important that we recognize the broad impact we can have in areas such as sleep, work, and social participation. And then the next phase then would be to identify what specific factors contribute to those challenges. So particularly with this population, we might see symptoms such as headaches or vision issues affecting those occupational performance concerns. And then once we've kind of identified what the challenges are, we collaborate with the client to really establish and prioritize goals. I think the important thing here is selecting and implementing appropriate task or contextual modifications to support their participation in meaningful occupation. So again, kind of that top-down approach to intervention as well. And then lastly, I think this is where we play a really big role with this population is in advocacy and education. So as Anna said, a lot of our participants had multiple concussions. So I think first educating the client on strategies to further prevent injuries, and then maybe also providing referrals to additional resources that they may need, and then really teaching advocacy skills to help them request things such as workplace or academic accommodations as needed. So again, that top-down approach, education and advocacy are really important areas.
I love that. Thank you for describing kind of this top-down approach, emphasizing education and advocacy. Is there any additional insight you'd like to give us into maybe some of the common complications that patients might be experiencing following a concussion, or how those, symptoms are really affecting their daily occupational performance?
Sure. People can experience a wide array of symptoms post-concussion, and post-concussive syndrome is not just a specific set of symptoms. Often symptoms can be cognitive, like decreased attention, difficulty with multitasking, like trying to answer emails if somebody comes to your office door, or poor memory, like remembering the name of someone you just met, or even to take a medication at a certain time. And one symptom area that surprises people sometimes is the psychosocial effects that we can see, like irritability or outbursts of anger or decreased interest in previously enjoyed leisure activities. Symptoms can also be physical, like dizziness or fatigue. And generally, post concussion, people are hypersensitive to stimuli like light or noise.
Thank you for highlighting those. It's sticking out to me how wide of a variety these symptoms can be and how these complications can be different for every individual person. And it's, because concussions impacting the brain, and the brain is literally connected to every body function. I think as OTs, we naturally see people holistically and are assessing for all these factors. What are the common difficulties that you see and how those symptoms are affecting someone's participation in occupation?
Matt, you mentioned there is a wide variety of symptomology, but I think as we started conducting this study, we kind of started to realize that there are certain trends in occupational performance challenges. They were starting to kind of emerge for us, which is kind of the reason for the second paper that we wrote when we analyzed the COPM results by itself. So I think as Ann and I were working with these clients, we kind of noticed these trends, and it really helped us better understand our clients and really allowed us to ask more specific questions about their occupational performance. So, we became better as interviewers and understanding the challenges they were experiencing so that we could really kind of dig in and figure out what was really going on. So in some of the cases, our clients didn't initially recognize that their challenges were significant. They were either, minor or mild, and they didn't really notice that challenge, or they kind of just accepted that these were unchangeable aspects of their daily lives. So when we administered the COPM to the 14 participants, the top three areas that were challenging were education, social participation, and instrumental activities of daily living. And I'll give some examples in each of those categories, how their occupational performance was an issue. So in education, the most challenging tasks reported in higher education settings were the use of computer and completing the reading assignments for their courses. For social participation, our clients highlighted difficulties with attending to busy social events, particularly those with loud or competing stimuli. So things like the coffee shop, or we did have several college students. So social participation activities of a bar scene. They also had a lot of challenges in maintaining relationships due to irritability, communication difficulties, and issues with follow through on plans. So a little bit of that time management with their social participation and other activities. In IADLs, we noticed a lot of struggles with grocery shopping. They had trouble meal planning and even managing that overwhelming environment of going to the grocery store. And then financial management was another big area of IADL. So keeping track of bill due dates and payments, and did I pay it or did I not pay it? I can't remember. And so those were the top three. However, there were three other big ones as well, such as work, health management, and sleep. And I feel like sleep was a particularly big, high priority goal for many clients. Once we kind of got their goals set in place, recognized all of their occupational performance challenges, I feel like one of the first 1 to 3 goals we really needed to target and work on was sleep for these individuals.
Yeah, each of those activities is so important to someone's overall health and well-being. And I love how you're demonstrating OT's unique value in helping people to improve in these areas that can be really debilitating and make it really difficult to function and live life in the way that they want to. I like how you already have mentioned the COPM. One thing about your publications, they highlight how existing literature relies on data from fixed item questionnaires to describe how post-concussive syndrome affects occupational performance. How would you say a semi-structured interview can be used to better address the unique needs of an individual with PCS?
Thanks for the opportunity to talk about this piece. This piece in particular was difficult to convey in the publication. So when we talk about fixed item questionnaires, we're basically thinking of a piece of paper with a certain amount of items on it that you hand to the participant, and they go item by item and check whether, I'm having difficulty with this, but not with that. And inherently, those fixed item questionnaires are strictly limited to the specific 10 or 20 items that they ask about. It's not part of the protocol to ask follow-up questions about those items. You certainly could, but for a variety of reasons, we often don't. Humans are complex with a wide range of occupations that we engage in, and just as importantly, how we engage in them. The task demands of something like weekly scheduling, for example, vary widely from person to person, and the nuances of that could be lost with fixed item questionnaires. Whereas use of a semi-structured questionnaire like the COPM that asks guiding questions, but also leaves room for exploring with follow-up questions, starts to remove some of those barriers. That allows clinicians to explore occupations in a more client-specific way and to gather more information on how that specific individual typically approaches those occupations. The stage of assessment is also a time that we begin to learn about what aspects of a task aren't going well and what the limiting symptoms or factors are. Use of that semi-structured questionnaire can also be a springboard for intervention planning. And I kind of want to harken back to one thing that Whitney said that's really of utmost importance, is that it allows a clinician to gather more data on what symptoms are impacting the individual's life, and they can blend that with clinical expertise, start looking for patterns, and that also guides which specific follow-up questions they ask, because oftentimes when you're put on the spot, particularly by a healthcare professional, about telling how symptoms are impacting your daily life, you're often not going to report each and every specific way that they impact your daily life. So having the OT there to ask follow-up questions really can provide a more well-rounded understanding.
Absolutely. I think that's such an important piece for clinicians to be able to ask those follow-up questions about those areas, especially the areas of performance that you're finding in your research related to education, social participation, IADLs, work, health management, sleep. I think were the ones that you mentioned. Such important performance areas in a person's life that may be missed without a semi-structured interview and followed-up questions and clinicians giving the patient an opportunity to discuss and relate how they're really experiencing these deficits. What additional recommendations would you give to practitioners to evaluate occupational performance deficits in an appropriate way?
Yeah, we've mentioned several of these, so I'll just kind of highlight those again. But again, this kind of top-down approach and identifying those occupational performance challenges first. So we've mentioned the COPM. I also like the goal attainment scale. It can be particularly useful in this process and helping the client identify goals and then setting what it would look like to achieve that goal. And then, as Anna said, for the many reasons that she identified, pairing these assessments with a thorough targeted interview really allows us to gather detailed information about those specific occupational areas they've identified on the COPM or the goal attainment scale. I think one thing too is that when we do have this interview, again, sometimes, we aren't aware of the symptoms that they may be experiencing, or they maybe aren't even aware. And some people don't want to admit that is challenging or that has become challenging. So if we kind of set these goals and ask these targeted questions in a safe way, then we might get more of a realistic response from the client too. And so Anna did mention there are limitations to certain questionnaires. I think tools like sleep logs or sleep-specific questionnaires can also provide us really valuable information if the client reports difficulty in sleep. We've talked a little bit about emotional regulation. So there may be some assessments or questionnaires that target anxiety or depression or quality of life. There are so many different versions of the promise that can maybe help guide insight to quality of life and emotional regulation that can further enhance. So again, pairing these with the other assessments that we've discussed, they can really enhance our understanding of the client's challenges. We also recommend including a functional cognitive performance-based assessment. As Anna mentioned, we have some of these paper and pencil assessments that look at like a cognitive performance skill, but we know life is complex and that cognition and that some of these occupations we identified, such as high-level IADLs and work and education, really require complex cognition or higher level cognition. So the opportunity to see these cognitive skills within a functional task is really beneficial and can provide a lot more rich insight. So we used the weekly calendar planning activity, which offered very valuable information into functional cognitive performance. Other tools such as the executive function performance test or the cognitive or more cognitively demanding instrumental activities of daily living tasks on the performance assessment of self-care skills, also known as the PASS, may yield useful data for us. And then again, I just want to kind of re-highlight a point Anna made, that it's important to note that the evaluation process is ongoing through intervention. So as you begin to guide the client to solutions and you learn more about their occupational performance and their context, you're going to get new information that will really help you to identify and better target some areas for intervention as well. So there should be a continuous reassessment that ensures that our interventions truly remain client-centered and effective.
Absolutely. Absolutely. Thank you for highlighting those principles of best practice. And we'll get back to our interview right after this quick message. You all know we really try to make research more consumable and applicable on everyday evidence. But did you know that just 1 minute of your time could help us to improve the show, improve the resources the American Occupational Therapy Association provides for practitioners, and improve the application of evidence to practice within our whole field? Please take our 1 minute survey. It's only 3 questions, and you can find the link in this and every episode's description, and support the AOTA in continued efforts to improve our podcasts and to improve the translation of research to practice. Now back to the interview. One of the greatest advantages, in my opinion, to using a cognitive approach to intervention is that continual evaluation and reassessment of performance and collaboration with the client to identify goals and strategies to incorporate. Your publications examine the effect of metacognitive strategy training, specifically with the cognitive orientation to daily performance or co-op intervention in adults who are experiencing PCS. What makes co-op an effective intervention for working with this population?
So we don't know quite yet if it's an effective intervention for PCS because of the limitations of our study design. So we just had an early stage feasibility study within PCS. So at this point, we can say that co-op is feasible or practical for addressing the occupational needs of those with PCS. And we can also say it was very well received by the study sample as being appropriate for meeting their needs. From our work, we did observe a sizable positive effect on occupational performance. And that was actually for goals that we specifically trained over the course of the intervention. And then we also had participants set at least one goal that we purposefully did not discuss at all during the intervention to kind of serve as a measure of skill transfer. And we saw positive effects on both those trained and untrained goals. We also saw positive effects for self-reported cognitive functioning in daily life and some concussion symptoms like irritability. We do know that metacognitive strategy training is a recommended intervention for other populations like TBI in general and for stroke. And because this population does have sufficient cognition and awareness to actually problem solve and develop those strategies, metacognitive strategy training seems like a reasonable fit to capitalize on those strengths.
That's really exciting to hear those outcomes from, this feasibility level research. And hearing you both describe the design of this study, the implementation, and the outcomes, it just makes a lot of sense that this would be a good intervention to implement as a practitioner. What would you say are some best practices for implementing this co-op approach during kind of the assessment and intervention steps of the OT process?
So the co-op, it aligns well first with the time constraints that's often imposed by insurance. So clients typically receive a relatively low dose of intervention, again, usually 1 to 2 sessions a week for 45 to 60 minutes over a few weeks. So we don't get a lot of time with these individuals, but they have a lot of goals. And so if you're unfamiliar with co-op, it's just a structured client-centered approach based on 4 steps. So it's goal, plan, do, and check. And so we begin by educating clients on these 4 steps so that they can generalize the approach to their daily lives across various occupations and contexts, both during and after our treatment. So we want our clients to be successful after intervention and during intervention our sessions and between intervention sessions. So it's just a nice approach that they can generalize to many aspects of their life. A key component of co-op is that it is highly collaborative. The process starts when the client identifies a specific goal. So which goal are we going to address today based on COPM or goal attainment scale or our interview? Here's some potential ideas, which is the biggest priority for right now. And then we can work with the client to analyze and identify where does the performance breakdown occur. Using guided discovery, we then help the client develop a self-selected plan. And again, I think that's the important part, is a self-selected plan to address the identified challenges. So we are not coming up with the solution for the client. We are using this guided discovery kind of coaching approach to guide them to a solution that we think will be successful, or I should say they think they will have success with when they leave our intervention session. The client is also given homework to implement the plan during the targeted occupation, and then they return the next session and we can discuss and evaluate whether that plan was successful. And that's kind of the check phase. So again, we want them to practice that plan, that strategy in a real life context. If needed, then we can collaboratively modify the plan to enhance occupational performance. So again, throughout the intervention process, we really focus on fostering the client's gradual independence in the use of that framework: goal, plan, do, check. This ensures that when they have a new challenge arise in their daily life, they have this really practical and adaptable problem-solving strategy so that they can address that problem effectively.
I love that. Goal, plan, do, check, and really empowering clients to apply those principles and that same approach in their own life as problems arise. And Anna, you mentioned the importance of skill transfer. I think in your studies, you were able to address skill transfer in such a creative and cool way with that goal that participants kept to themselves. What can practitioners do to increase the likelihood of skill transfer during treatment with co-op or with another metacognitive strategy training approach?
I think the key goal of co-op is generalization of its cognitive strategy, and its foundational principles are designed to foster skill transfer. So that's really exciting. It's kind of set up to do this for us if we implement it well. And so first, again, prioritizing occupation-based practice. We ensure that the task and environments during the session closely mirror real-world context. So this allows the clients to practice the strategy in a meaningful and relevant way. So for example, if the strategy involves using some sort of feature on their phone to set a reminder to pay a bill or to create a grocery list, then we can actively practice that together during the session. And again, that's a strategy that they've identified. Second, the homework piece is important. So they're given a homework to apply the strategy in their real world context. And then they know that they are going to have to report back to us how that strategy worked in their daily life. So early on in the research process, in the kind of protocol process, we provided a co-op worksheet where the goal and the plan are clearly written out before they leave the session. And then they fill out kind of the do and check sections based on their experience. And that provides kind of a checkpoint that they have to bring back to us and discuss, and helps enhance that skill transfer. Again, another critical component, we talked about this a little bit, is the client develops their own strategy. So this approach increases the likelihood of skill transfer and carryover at home, as self-identified strategies are often more meaningful and practical for a client compared to those that we may impose on the client. So during the plan or check phase, it's important to ask questions that help the client analyze the area of difficulty, so that we can identify how difficult it may be for that strategy to be implemented at home. And then if it's very difficult, then we maybe need to rework the strategy a little bit so that they can have success at home. We might even ask questions like, on a scale from 1 to 10, how likely are you to use and implement this strategy? And then kind of a good marker from some other research is if the response is below 7, we collaborate with the client to revise the strategy so that it's realistic and effective, and they're confident that they can go home and implement the strategy that they've identified. Guiding the client towards habit formation is crucial. So these strategies must be implementable in their daily lives, which is why fostering autonomy and providing opportunities for decision-making are really powerful components of skill transfer. And then from my personal experience working with this population, I have found that once we got a little bit of client success with their first 1 or 2 goals, their buy-in to goal plan do check framework increased significantly. Clients often began to notice the meaningful changes in their daily lives, and they started using the metacognitive strategy independently, becoming their own agents of change. So they didn't even realize sometimes that they were using it. They would come back and they would be like, I encountered this occupational performance issue or this challenging aspect in life this week, and here's what I did about it. And so it was really nice for them to kind of just start being their own game changers in their daily life without this like formal guidance of a therapy goal plan do check session. And that's exciting when you see that generalization and carryover.
That's what every clinician hopes to see and wants to see. I think the work that you two are doing is such a beautiful example of both the science and the art of occupational therapy and the impact that strong clinical reasoning and evidence-based approaches can bring into someone's life. How would you recommend a practitioner really implement guided discovery methods throughout the OT process to facilitate those improved outcomes and that increased generalization for the patient?
That's a great question, and it can be a difficult skill to learn. OTs have a lot of knowledge on how to improve occupational performance, and we're so eager to share it. And because of setting constraints and insurance constraints, we're usually forced to be very efficient in our evaluation and our treatment. And the result of all of that clinical expertise and those time constraints sometimes is very direct, rapid fire communication, which can reduce their chance to become that game changer, like Whitney said. If we give our clients all the answers, we reduce their opportunity for problem solving and mastery. So my biggest piece of advice is just to try it out. Know that it's a clinical skill that takes time to develop, but then eventually it becomes second nature. So much so, it may be how you actually start interacting with your partner or your friends too. Start by just using open-ended questions and know that your line of questioning may lead to a solution that you don't expect. And that's okay. And actually, it might even be better. You could also look into coaching literature as well.
I love that. Those are wonderful recommendations. Maybe some practitioners out there can goal plan, do check their own approach and try and, set some goals to incorporate more guided discovery into their treatments.
Absolutely.
Could you share an example of when you've implemented a metacognitive strategy training intervention that contributed to a positive outcome for a patient?
This is one of my favorite examples. So we worked with a police officer, and he had sustained multiple concussions on the job. And he had seen several professionals and kind of come to accept that his difficulties were just a part of his new reality. I think maybe was even a little hesitant to enroll in the study, but was kind of thinking, let's give this a shot. I've tried a lot of other things. He was struggling with sleep and experiencing some irritability due to the stress of his job. Additionally, he felt that he needed to vent to his wife about work and his challenges, but he was worried that sharing like heavy information might really strain their relationship. So again, we see kind of these trends of work challenges, of sleep challenges, of relationship challenges. So through several rounds of goal plan, do check process, he eventually developed a strategy that worked for him. We did not find the strategy the first couple of times. And again, I think this is really important where the client self-selects. I could have given a strategy and perhaps we would have had the same result, that it would not have worked. But we eventually worked through this process, and he really began to journal about his stress, his thoughts, his feelings. And another meaningful strategy for him was listening to podcasts that kind of helped with sleep. So he was a big runner and really enjoyed kind of listening to podcasts that were more meaningful to him. So about running, his wife liked to run as well. So over time, they even began to listen to these podcasts together, which also strengthened their relationship and kind of helped them decompress before bed. He later reported that these changes transformed and even saved his life. And this is the thing that I love the most. He is now a leader in his police department, and he advocates for these practices among his colleagues. He encourages them to really journal or even explores other ways to decompress because the job is stressful and it's going to impact their life in some way. So he really emphasizes the importance of these strategies for officers dealing with similar stressors. And so just, again, highlights like self-guided solution there. Maybe not one that I thought he would have picked or one that would be successful, but after many rounds, that was the one that really stuck and made a huge impact on his life.
Absolutely. Thank you. Anna, can you go ahead and share another example of someone you were working with?
Sure. So the one person that really sticks out with me was a 20-year-old that I work with who had experienced a concussion during kickboxing a year or so prior. And before the concussion, he was top of his class, had near perfect scores on standardized tests, and was very active socially on campus. And then after his concussion, he noticed changes in his social circle, plummeting grades, and was actually about to drop out of school and lose his full ride scholarship. When he attended social gatherings after the concussion, he said he would have difficulty with the loud, constant noise and have a hard time following conversations with multiple people and become overwhelmed by all the stimuli. Some of the strategies he ended up implementing were to be selective of which social gatherings he attended by thinking about the size of gathering and the importance of the people there to him. He also intentionally would limit his time at the social gathering and intermittently do a self-check of his symptoms while taking breaks outside. He would take proactive steps like positioning himself away from louder parts of the environment. And he also talked a lot about how his personal relationships suffered as well. He expressed discomfort with maintaining prolonged eye contact during conversations, even if it was with someone he was close to. He repeatedly forgot to answer emails and texts and would sometimes become irritable. And part of his plan, at least temporarily, was self-advocating and telling those he was close with about his symptoms and how he was changing his approach to handling them. He established a habit of checking text after each mealtime so they wouldn't go unanswered for such long periods of time. And since then, he's completed his degree while maintaining his full ride scholarship and is pursuing a career that he loves.
Wow, such impactful outcomes, and a wonderful testament of using this approach to therapy and collaborating and emphasizing, a client's needs and goals. And it just clearly illustrates to me how the generalization of these techniques and strategies can have such a large impact in the performance of someone's most meaningful occupations, and just a huge impact in their life overall. I think this is an approach that requires a certain level of trust in yourself as a clinician, and also trust in your patient, in your client, in the people that you're working with. What additional resources related to occupational therapy and post-concussive syndrome would you recommend to our listeners?
Obviously, AJOT has a lot more publications than what it previously had. And so exploring those options as well are great. There's also some other great literature out there from other disciplines that we can begin to explore. Always encourage the use of some podcasts as well that maybe highlight some client experiences or other great strategies. Anna also mentioned too, the coaching literature is also a great point. I am not great at guided discovery and still am learning that process and how to ask the best questions at the best time and in the best way. And so I think even looking to some of that coaching literature and practicing with other individuals is a great way to just start.
I love that. And we end each episode with the golden nugget segment. If you could share one piece of advice or one recommendation with practitioners, what would you say?
There's never just one piece of advice. So I have a couple. So first and foremost, remember that the client is the expert in their own life. So let them take the driver's seat in the process, and it will have a great impact on your outcomes. And that really goes for any population as well, not just this population. And then secondly, approach the evaluation with curiosity and a really thorough investigation of all domains of the OTPF. So remember, we are good at collaborating with clients in the areas of sleep and social participation and health management. And those areas often require a lot of targeted questions because the clients may not be thinking about them, and they may not be at the forefront of traditional rehab, which tends to be a lot more ADL or IADL focused. However, these less often domains are often significantly impacted, and they can really provide key insights into the client's challenges and priorities, and therefore just really enhance their quality of life.
Start challenging yourself to be a collaborator and a facilitator to foster your client's learning, and less so as an expert. Even though you are the expert, really layer that into using your expertise to support your clients' overall learning. Because again, since we have such a limited time to address the needs of our clients, they really need to be empowered to be a problem solver on their own, so that when they encounter other difficulties that you haven't discussed, they're able to do so.
Those are wonderful recommendations, great golden nuggets, and truly keys to a sustainable improvement or a sustainable approach to therapy. Anna, Whitney, I want to thank you both so much for your time, for being on the show today. Real quick, can you tell us what are the next steps in your research?
So the next steps, now that we know it's feasible and it's practical and well received by the population, would be to begin moving towards an efficacy trial. So you asked earlier, how do we know it's an effective intervention for PCS? So the next step would be having a study with a large enough sample size that we would be well powered to answer that specific question. How effective is it?
This is something that's really needed and can make such a large impact. So thank you both for doing this work. And we'll keep following what you're doing and would love to have you on as recurring guests to get a follow-up when those next steps are being completed.
Sure. Thanks for having us on, Matt.
Yes, thank you so much.
Thanks for listening to Everyday Evidence. Tune in next time for more evidence-based practice insights and applications.